site, the Facebook site.
We're on live now. So, okay. Good morning, viewers. Welcome to another episode of Monitor Your Health, the program where we educate the public about health, contemporary health situation in Nigeria and around the world. Today, we have in the studio a renowned neurosurgeon, Dr. Douglas Okor. You're very much welcome. We will be talking about the position and situation of neurosurgery, service in Nigeria, and see how people can tap into this service, and then to know, times and when you actually need this service. So, Dr. Okor, please, can you introduce yourself to our audience?
Yeah, I know most doctors, they like the DRs in the doctor thing, but I'm trained in the UK and usually we're called Mr., isn't it? So usually I just myself without the Mr. the doctor. So my name is Douglas Emeka Okor. I'm a consultant neurosurgeon. Most of the work I do in Nigeria, I'm based in Abuja, is private. I was trained in the UK and I moved back to Nigeria about 3.5, 4 years ago. I've been back in Nigeria for about 4.5 years now. Basically, that's me. Maybe as we talk along, even though we're talking about neurosurgery, because I'm talking about some personal experiences and all that as well. And just to say, Dr. Ogunremi, Femi, before we go ahead, I want to say a very big thank you to you and the Monitor Health team. You guys are doing an absolutely fantastic job when it comes to health promotion, advocacy, and health education with all the work you're doing in terms of cancer care, cancer prevention, and all that. So, big up. I had to say that before we continue.
Thank you so much, Dr. Okor. I remember the first time we met in Sheffield.
Yes.
That was about 5 years ago. And I told you, we will be meeting in Nigeria again, if you remember.
Yes.
That.
And here we are now.
Yes, here we are. Thank you. So, right. So neurosurgical, service in Nigeria. What do we even mean by this service? What does it mean?
So basically, people hear about neurosurgery. Neurosurgery is actually brain and spine surgery. Okay, so neurosurgery is brain and spine surgery. So neurosurgical services is all about providing healthcare services to patients who have medical conditions that affect their brain, their spinal cord, their spine, and the nerves that subset the rest of their body. Now, people might be wondering, why do you say spine and say spinal cord at the same time? So if everybody viewers, if they know about anybody has eaten fish, if anybody has eaten fish, because that bone in the center of the fish that has the different appendages coming out like that, that is the spine. That bone is the spine. Okay. Then there's one soft sort of tissue going in the middle of that bone. That is the spinal cord. Okay. So you have the brain, which is the engine, the generator that generates all the electricity. And that generator needs to actually pass all the electricity through a big cable of wire, which is called the spinal cord. And then you have the smaller cables of wire, which are the nerves, to actually subserve and pass the electricity to the rest of the body, which are like your fan, your TV, and stuff like that for them to work. So that's generally how the nervous system works. So basically, neurosurgery is all about treating patients that have medical conditions that affect all these parts of the body I've enumerated. And usually, looking after these patients will entail making first of all, prevention, making a diagnosis, okay, treatment, and more often than not, more than 85–95% of these treatments will actually be surgery, okay? And of course, rehabilitation as well. So that's what neurosurgery is all about. Now, the neurosurgeon, who is a surgeon who does all these operations, usually leads the team that provides neurosurgical services. But the neurosurgeon is not the only person within that team. There are other people who actually make up that team, okay? Be it the anesthetist, the neurologist now again comes to work with them, the physiotherapists, definitely the nurses, the critical care staff, okay? Even the porters and hitmen are all important. In healthcare, it's all about the multidisciplinary team. So generally, that's what neurosurgery is all about. Of course, neurosurgery has subsets, you have subspecialties in terms of neurosurgical services, and probably I'll talk about that later.
Brilliant. So I know, in Nigeria, there are, what you tend to see is people have issues around their brain, they have issues around their spinal cord. The next thing is they're looking for a way of getting to India. They're looking for a way of getting out of this country. So the thought and the belief of the people is that this service is either non-existent in Nigeria, or if it's existing, it's not of good quality. People do not believe in it, if that makes sense. So what, if you can you tell us, maybe if it's possible, tell us the history of how we arrived we're here? Because I remember when I met you in Sheffield, those days back, I'm not sure whether you were just finishing your training then.
I think I was just about finishing then.
Yes. So, and then we were talking about it, this service in Nigeria, or things like that. We're both thinking, oh, I want to go to Nigeria. You also want to go to Nigeria. And so, oh, we're going to connect there. So it's like babies or kids playing with candy that they know, so what's your view about the history so far? Why is it, how did we get here where people do not trust this service in Nigeria?
Okay, so Femi, before I go to the history and bring us to the present, okay, let me state something categorically, make something very clear here, okay? The healthcare system in Nigeria is a broken one and has been broken for a very, very long time. When it comes to the issue of actually having the general confidence that the people will have in the healthcare system, the confidence is generally not there. Surprise, surprise. We all know why. Okay, now, after saying that, let me go back. How did all this begin? The first Nigerian neurosurgeon, who was actually the second African board certified neurosurgeon in the US, the second black man to become a neurosurgeon in the US, was Professor Olatunde Odeku of blessed memory. Okay, he started the first neurosurgical service in October 1962 in University College Hospital in Ibadan, in the Premier Hospital. Okay, he was alone then. He was then joined after a few years by another chap called Professor Adeloye. But Adeloye was, I don't know, I met him up in Sheffield. Adeloye actually stayed in Sheffield. Okay, he was the second neurosurgeon. From there, other centers actually opened up in 1968. Colin Da Silva opened up a neurosurgical unit in Lagos. Professor Igbolam opened up a unit in the eastern part of Nigeria, in University of Nigeria Teaching Hospital. And then recently, towards the end of the 90s, Professor Shehu Bello, who actually trained in the UK and Ireland as well, came back and established units and trained more. In fact, he's like the father of neurosurgery in the northern part of Nigeria. Do you understand? So, moving from that time till now, I remember in the late 1990s, 1998 or so, when I decided to become a neurosurgeon, there were very few neurosurgeons in Nigeria. I don't think there were more than somewhere between 10 to 14 then. Okay? But over the years, things have really progressed in terms of the numbers that we have, in terms of the training centers. From about 2 training centers at one point, we now have roughly about 10, 11 training centers in Nigeria, spread across the country. So in terms of the numbers are significantly appreciated. Presently now in Nigeria, I think we have roughly somewhere between 80 to 90 practicing neurosurgeons in Nigeria. Okay, so the number has moved from where we were before. For a population of 200 million people, is that enough? Absolutely not. But at least we gained a little bit of traction in terms of moving the numbers upwards. Okay. Now let's look at what are these services like in Nigeria in reality. Okay. If we look at the public sector, for example, so training for neurosurgeons happens more in the public sector. You have centers in the University College Hospital, which is like the premier center. Definitely in Lagos, you have like 2 centers that do training. One center that does training. In the East, you have 2 centers, 1 teaching hospital, and also a private place as well. There's actually a private neurosurgery center in Enugu in the East that actually trains neurosurgeons. There's one in Benin. There's partial accreditation for the chaps in Port Harcourt, in Kaduna and Kano as well. We actually have training centers. There's roughly about 10, 11 training centers. So we've done a good job when it comes to producing the numbers. Now, when it comes to the issue of properly organizing these services, the human resource for health, the training, the competence, the capacity, you understand, the knowledge base, the experience, okay? And when I talk of competence or the technical capacity, I'm not just talking about being able to do operations. I'm talking about the other things that we always forget, which are significantly important. The soft skills, the non-technical skills, the ability to lead, the ability to manage resources, both human, financial, and the physical resources as well. The ability to communicate effectively, the ability to work in teams in a multidisciplinary team, the ability to empathize, the ability to understand the meanings and the underpinnings of what we call patient-centered care. We are struggling, Femi, and I won't lie to you, especially within our public sector. Especially when we are struggling really badly. Like I said, we've improved the numbers, but when it comes to the realities of delivery service on the ground in real time, we are struggling very bad, as I said, especially within the public sector. So when the average Nigerian has any neurological problems, any neurosurgical problems, and the first thing he thinks of is, hey, man, brain, spine in Nigeria, I need to run. I don't trust it. I do not blame them at all. But guess what? In the last 10, 15 years in Nigeria, there have been significant improvements in terms of the technical capacity, in terms of general capacities to actually provide such care. Okay? Now, if we break down the different subspecialties in terms of providing the social service, we can break them down into number one, trauma. Okay? Trauma, head injuries, spine injuries, and stuff like that. So that's, we call it neurotrauma. Okay? Second one is neuro-oncology. Neuro means brain, oncology means cancer. Okay? So people who have brain cancer, brain tumors, and all that. Okay? Then we have another subset is pediatric neurosurgery. The subset of children, adolescents, they can actually have problems that are usually specific to them. So that's pediatric neurosurgery. Then there's vascular neurosurgery. People who have strokes, who have bleeds in the brain and all that. Okay? And then you have what we call skull-based neurosurgery. For example, operating on people through the nose for skull-based tumors and any skull-based pathologies at the base of the skull. And of course, we have what we call functional neurosurgery. Okay? And then of course, we have spinal surgery, ranging from simple spine to complex spinal services. Okay? Now, functional neurosurgery, where you look after patients who have epilepsy, for example, and who have things like Parkinson's disease. Believe it or not, Parkinson's disease, people have things like essential tremors, and people have pain where you have to actually put deep, what they call it, spinal cord stimulators and things like that. That sort of surgery, functional neurosurgery, is really a high-level neurosurgery in terms of competence, in terms of the hardware, in terms of the human resources that you need to provide such care. And what I usually tell people that at the present time in Nigeria, 2020, September, more than 85%, and I stand to be corrected, more than 85% of pathologies or medical problems that will affect the brain spinal can be looked after in Nigeria and looked after properly in Nigeria. Okay? The other 15% will be things like functional neurosurgery. At the present point in Nigeria, you cannot provide functional neurosurgery care. Yes, in fact, the next, my own thinking is that if I look into the future, it will be like up to the next 15 years at least for us to be able to provide that kind of service. Besides, that kind of service is not what we need now. The basic fundamental service provision in neurosurgery is what we need to be holding on. We need to be building on that. So when it comes to what neurosurgery is all about now in Nigeria, especially there are private sector players that come in and are now doing a fantastic job in terms of raising the standards and raising the bar and providing neurosurgical service that is of some level of quality and safety. And like I said, I'll repeat this, 85% of people who go out for neurosurgical services do not need to go out.
Wow, that's that's staggering to me because the impression, general impression is that it's not working, and I see you've actually laid down some of the fundamental things that are really not in place, probably that is drawing us back. But 85%. So yes. How do we? Because people need to know this. A lot of people we run this app where people call in and things like that. A lot of people have received call, people are asking, I want to go to India, I want to go to this for treatment and things like that. So how do we then, what are the things that we need to put in place to let people know that this service is actually, in terms of evidence or evidence is available, that we're actually doing well, we can handle it. And then then that can bring trust to the system that we're running, because a lot of people do still not believe they do not believe in the system here. That's the gospel truth. And I
totally agree with you. I totally agree with you. So the question is, what should we be doing? The traditional ways of doing things are when, especially within the healthcare community, the medical community, say, our medical conferences, we do peer-reviewed publications, that's where we put our work out and stuff like that. But guess what? The average Nigerian doesn't look at all those things, doesn't come to your conferences, doesn't look at your peer-reviewed journals, doesn't read your books that you do and stuff like that, okay? Now, because we have been struggling with healthcare when it comes to a broken industry for a very, very long time, and the average person has lost faith, that means you now have to think of innovative ways to actually put the information out there and actually show what capacities we have in Nigeria. Okay, one of the first things I did when I came back to Nigeria was I started doing videos, for example, using videos and using social media. And some of my colleagues, guess what some of my colleagues have said? Oh, you're advertising yourself. You know, we don't like advertising. And I told them, no, I'm not advertising anything. I'm providing very critical information for the average Nigerian, and the average Nigerian needs to know what capacities you have in Nigeria. You cannot have a neurosurgical problem, you go online or you try to look for, and the closest person you can get to is someone in India. Meanwhile, just let's go to you, things are happening, and they're providing such services. I think this is absolutely important. And guess what? By leading from the front and actually making sure that I push this sort of innovative ways of trying to promote what's happening on the ground in Nigeria, educate Nigerians and all that, little by little, other people are taking it up now. So now you're not seeing more videos, more pictures, more information. I go to churches, for example. I go to churches, do advocacy, talk about brain and spine issues and all that. Okay, and I show pictures, videos in real life. There are times when I put videos out about complex brain surgery cases, and some people are like, are you sure this is in Nigeria? Are you sure this is in Nigeria? I'm not sure this is in Nigeria. So, but it is happening, okay? And little by little, we'll keep building up. We are not where we need to be. Definitely not. Definitely not even by stroke. But these things are happening. So the key answer here is that we need to look for innovative ways to actually put the word out there that things are happening in Nigeria that people never ever believed could happen in Nigeria. And what we are doing now, Femi, this conversation we are doing with other people joining in is absolutely important. This is the way to go.
Thank you so much. So let's now break it down. Let's break it down and see, you know, in terms of, because I've seen loads of these your videos. They really, I mean, as a medical doctor, when I look at that and I compare the quality of what I see in that and what I've seen in the UK and things, I mean, I'm quite impressed. And that's why I thought, look, you need to come here and let us know that this service actually exists in Nigeria. So if we're to break it down, what sort of conditions can we, I mean, in terms of one after you talked about, you know, things like, so what are the conditions that people think, like now they think it's impossible, it's not doable. I have, you know, as we're talking, I think some of the people might be watching who have contacted me before that they have issues. Maybe they've had road traffic accident. They suffered, you know, spinal injury. They can't walk and things like that. And so, do I have hope? You know, they're asking that. So, what are the conditions that we can handle?
Okay, so basically, like I said, basically almost all the conditions we can handle in Nigeria, apart from functional neurosurgery. I specified that before. Apart from functional neurosurgery, but of course, my job is to actually break it down to make sure that the average person understands. So let's, I'll go through the subspecialties again and then start taking them one after the other. So I talked about trauma, okay? Neurotrauma, brain and spine trauma, okay? Second one I talked about was vascular neurosurgery. We'll talk about strokes and bleeds in the brain and stuff like that. Third one I talked about was the pediatric neurosurgery, where you have children and adolescents that have problems that affect their brain and the spine, okay? And the fourth one was, we talked about neuro-oncology. We talked about brain tumors, spinal tumors and stuff like that. And we talked about spine, doing spinal cases itself. And then we'll not talk about functional neurosurgery. And then we'll talk about skull base as well, okay? So in neurosurgical practice, provision of neurosurgical services, almost 40, 45, 50% of the service that you provide are emergencies. Okay, they're emergencies. So let's talk about emergencies. I'm sure that's the one that people really want. Emergencies. I have an emergency. What do we do? Okay. Yeah. So the two key medical conditions, two key problems that any patient will have that will be an emergency that you need neurosurgical input are trauma and stroke. Let everybody be clear with that. Two things I said: trauma and stroke. So let's start with trauma. So trauma can result from what? Few things. Road traffic accidents. That happens a lot in Nigeria. And when you're looking at trauma, you're talking about an impact to the head or an impact to the spine. Okay, so trauma. Second thing, fall from a height. Somebody is walking in the ceiling or something like that, something breaks and falls from a height. Or actually falls from a building, or a baby falls from a building when maybe the family is not watching. So it falls from a height. Okay? Yeah. Industrial accidents, working with heavy machinery, something moves, hits you or something like that. Okay? Sport injuries. Okay, you're playing football or playing basketball or playing rugby, you tackle somebody and then you actually had a head injury or a spine injury. And then assaults, gunshot injuries. Okay, you know what happens in Nigeria, all the kidnappings and stuff like that. So that is trauma. Okay. Now, one of the major problems we have in Nigeria, major big problems, and again, I'm not surprised that anybody doesn't trust what's happening within the system, is our pre-hospital care. What happens to you there where you are when you fall, or when you have a gunshot injury or whatever? What happens to you from there before you get to the hospital?
Yeah.
Okay, so one of the first issues is the first responders. Who responds first? Your Nigerian emergency maintenance agency or whatever, your federal road safety corps. Do they that might be the first responders? Do they even have the capacity? Are they well trained to be able to rescue someone, or are they well trained to provide that pre-hospital care before the patient gets to the hospital? Because that's critical. That's really critical in terms of whether the patient survives or not. There's what we call the golden hour. What happens within 1 hour when the patient sustains trauma to the head, spinal cord, or any part of the body for that matter? So pre-hospital care is a major issue. Now, if you're lucky and some sort of pre-hospital care comes to you, and you're able to come, you're able to get from the where the incident happened, and you're moving to a hospital. The next question is that what hospital do you go to? Which facilities have the capacity to actually manage a patient who is that critically ill? So another major problem is information, is data, is being able to that information that everybody knows that, hey, this particular hospital, this particular facility has the capacity to actually manage such a patient. Okay. Yeah. Of course, the other issue will be if you finally get to that hospital and stuff, what are the issues in terms of payments, financing healthcare? Right? There's an emergency and stuff like that. So those are some of the issues. Now, when a patient has trauma, has had a road accident, or has been involved in a traumatic experience like this, what happens when you get to the hospital is also very, very important. Okay, and I think I need to establish this very, very clearly. Very, very clearly. Usually, sometimes when I'm talking to families, or even talking to even medical students, or even young doctors, I ask them, do you guys watch Grey's Anatomy? Do you watch The Residents? When a patient who's critically ill has sustained injuries from an accident, when they come in through the door into a hospital, is it the neurosurgeon they see first? It is not the neurosurgeon. It is the guys in A&E that they are responsible for resuscitating the patient, of trying to stabilize the patient first, and all that. That is actually what saves the patient, not the neurosurgeon who comes in maybe 2 or 3 or 4 hours later. So that ability to actually stabilize the patient, check the patient's airway, breathing, what we call the advanced trauma life support protocol and all that is actually critically important. And I can see that person will fall down very, very badly in the country across board, really, really badly. Okay, that ability to actually resuscitate the patient, stabilize the patient, assess what the patient is like, and if you need extra hands, then getting them in. For example, if you assess a patient and the patient is unconscious, and there are actually objective ways to actually assess that, you need to make sure that the critical care staff, the anesthetists, come down and review that patient, because that patient might need to be intubated, putting a tube down the patient's windpipe, and connected up to a ventilator and deeply sedated. That is what we say to the patient. So a patient coming into a hospital is unconscious, has head injury, has chest injury and stuff, and the patient is in one corner in an A&E and stuff. That happens a lot in Nigeria, doesn't it? It happens a lot. So you wonder why we don't trust what's happening in Nigeria. So that resuscitation of the patient, getting the anesthetists in to actually make sure that we stabilize, make sure that we have an airway, make sure that the patient is stable before you get a diagnosis. That's absolutely critical. Because if the patient comes in, is in a bad way, and you start rushing the patient off to get your diagnosis, to get the scan and all that, the patient can die in your scanner. Yeah. Okay. So resuscitating and stabilizing the patient, getting anesthetists involved if you need to, is critically important. Then you now get your scan or get your X-rays or whatever. And then when you now find that things are happening, you now call in whichever specialist needs to actually come on board. And that's one of the things I found since in the last 3.5, 4 years I've been on ground in Nigeria. A patient comes with a head injury and they're calling the neurosurgeon. Meanwhile, they've not done the specific things they should do in terms of resuscitating the patient and stabilizing the patient. So please, any healthcare professional, please pass the word across that the pre-hospital care, what happens when the patient hits that hospital, hopefully the hospital has the capacity to actually manage the patient. What happens those early periods, those first 2 hours, first 3 hours is absolutely critical, and it is not the specialist that you need at that particular point in time. That's really, really important. Really, really important, because what happens is that usually when you have a traumatic injury to the brain or the head, the primary injury has happened already. Everything you're doing from then is to prevent secondary injury. And what happens in our climate is that we actually have a significant number of patients getting to secondary injury because that resuscitation and that early intervention is not happening and not happening appropriately. So this is a very strong message going out. Okay? Now, so we've talked about trauma. The other thing that brings patients as an emergency into a neurosurgical services is stroke. Now, I use stroke as a generalized, it's a big term, isn't it? But I'll have to break stroke down. Stroke is anything that has to do with the blood vessels supplying the brain, where something acute or sudden happens that happens to the blood vessels supplying the brain, and then there's actually problem or dysfunction or damage to the brain. Anything that affects the blood vessel and then now affects the brain. That's stroke. Okay, so we can now divide stroke into what we call ischemic stroke and hemorrhagic stroke. Big words, but what does it mean? In ischemic stroke, you're talking about a stroke where the blood vessel supplying a particular area of the brain is blocked by blood clots. It gets blocked by blood clots, and then the part of the brain that's being supplied by that blood vessel is not having blood anymore. And that's the problem with the brain. The brain, the spinal cord, and the nerves, they are permanent tissue. What do I mean by permanent tissue? There are three types of tissue. There's labile tissue, there's stable tissue, and permanent tissue. Labile tissue are things like your skin. If you cut your skin or you cut your intestine, it heals up very, very fast. Okay? Stable tissue are tissue that they heal, but they heal very, very slowly. Something like your liver. Cut your liver and give some to somebody else. That liver will actually grow back very, very slowly. Then the brain and the spinal cord and nerves are permanent tissue. They are very unforgiving. It is very difficult for them to regenerate, very difficult for them to heal. That's why you see when someone has had a stroke, is walking like that, on one hand and one leg is weak, that they hardly ever recover. It's hard for them to recover to exactly the state that they were before. So one of the things we always say, especially with whether trauma patients, whether stroke patients, is that time is brain. The speed at which either the pre-hospital care, the care in the A&E, or the care in the critical care area, in the ICU, or the neurosurgeon intervene, the speed at which you intervene is absolutely important and is directly proportional to the amount of recovery the patient will have. Please, that's another very clear, because I'm sure most lives are really interested in this. Oh, if you have a brain problem, have a bleed in the brain, or have trauma to the brain and impact in the brain, will you recover? The response, the speed of response, the timing of the response is directly proportional to the amount of recovery, or if you have any recovery, or the reversal of symptoms. It's absolutely important. And that's why that speed is so important. And of course, when it comes to response in Nigeria, in every sector, not that it's not painful in the health sector because we're dealing directly with life and with living. The response is abysmal. Big word, but it's terrible. Absolutely terrible. You can say I'm passionate about this. Absolutely terrible. Because the attitude across board, you understand, is terrible. Absolutely terrible. And that's why this whole thing of rejigging the whole system and really trying to wash our minds. I wish there was something we can all drink and really wash our minds. It's absolutely terrible. Absolutely terrible. Okay? So this thing of this holistic rejuvenation of our minds and that will actually transform the way we actually think and the way we act is absolutely important. Thank God, Femi, that culture is dynamic and culture can change. In my own area of small influence, with me standing my ground and telling people that, hey, despite the fact I'm in Nigeria, with the inefficiencies, with the gaps in the system, I will maintain a standard, and anybody who works with me will come up with that standard. Man, I can tell you, even just in my small area of influence, Femi, things are happening. They initially, many people who walk around me, they always say, oh, they don't like me. And I keep telling them, please, ladies and gentlemen, you don't have to like me. My wife and my children like me. That's enough for me. You don't like me. It's a paradox, isn't it? You don't like me, but whenever your father, your cousin, I'm the one that you cover, you don't like me. Okay? And I keep telling them, like, if I was trained in Nigeria, or I have the average Nigerian work ethic, I won't like myself as well. So don't worry, I understand. But as long as I'm leading any team or leading the provision of any service or leading the care of any patient, everybody will rise to the occasion. Because like I always say, Femi, the Nigerian patients are worth it. If the guys in UK or US or other European countries get good care, the Nigerian average can get it as well. So we have to keep working towards that. So yeah, so stroke as well. So different type of stroke, like I said, ischemic stroke, a block in the blood vessel, and there's a second type of stroke, the hemorrhagic one, where a blood vessel actually ruptures or tears, and there's a leak of blood from that blood vessel into the brain. Okay. Now there's what they call the cranium. Okay, the skull. Your skull is the bone of your head there, your forehead, your face, your jaw. So that's the skull. Now this part of the skull from here upwards that houses the brain is called the cranium. Okay, so intracranial means inside the cranium. Okay, the brain inside the cranium. So you can actually have bleeds in different parts of the brain. okay, either from trauma or from stroke. Okay, so from trauma, so you have the skull like that. Okay, the skull is under your scalp, under your skin. Okay, you have the skull. Under the skull, you have a membrane that covers the brain. It's called the dura. Okay, now you can actually have a crack in the skull or a tear in one of the blood vessels just around that membrane, and you have what we call an extradural hematoma. Extra means outside that membrane covering. Okay, so the blood is not in the brain, but it's outside the membrane covering. It's actually putting pressure on the brain. Okay, you can also have a blood clot under the dura, under this membrane, but on top of the brain. They not call it a subdural. Okay, and then you can have an intracerebral bleed or intracerebral blood clot. That means cerebral is brain, so inside the brain. Okay, you can also have a subarachnoid bleed as well. So the subdural bleed I talked about under the membrane and the extradural hematoma, usually those occur from trauma. You can actually have a bleed inside the brain from trauma as well. Okay, now let's talk about strokes. A bleeding from stroke itself can either be inside the brain, which is intraparenchymal or intracerebral. It's actually inside the bleed inside the brain. The common causes of that are high blood pressure. That's the most common cause. So when we tell people about, hey, you need to look after yourself, you need to make sure that you go see your family doctor, make sure you do your blood pressure checks, make sure you do your blood sugar checks, do all your routine tests. These things are actually very serious, especially after the age of 40. Okay, but funny enough, we're actually seeing high blood pressure in younger patients. You see patients, young people, 35 years old, they're having bleeds in the brain because of poorly controlled high blood pressure. Really important. So healthy living is also really important to try and prevent all these things. So a bleed in the brain, usually from high blood pressure. You can actually have a bleed into the water. There are water spaces in the center of the brain. They're called ventricles. You can have a bleed in the water spaces in the brain, what we call an intraventricular hemorrhage. Intra means inside the ventricles. So you can have an intraventricular hemorrhage. Usually that is usually from high blood pressure as well. Okay. You can also have what we call a subarachnoid hemorrhage. Big words, isn't it? The subarachnoid layer is just that layer just outside the brain. That layer that just covers the brain. It's under the main membrane, the dura, but that area that plasters the brain is called the subarachnoid layer. So the most common cause of a spontaneous, from nowhere, a bleed, a part of stroke, type of stroke as well, is an aneurysm. Okay? An aneurysm is a weak spot on the blood vessel. The two key predisposing factors are smoking. So for those who smoke, I might be treating your aneurysm in the very near future. Okay? It's smoking and high blood pressure. Please let nobody forget this. Two key things: smoking and high blood pressure. Okay? In patients who have aneurysmal bleeds or who bleed from this blister or this aneurysm, about 30% of them die on the spot. They don't make it to hospital at all. Okay? And if this aneurysm, if it bleeds again the second time, the fatality is about 80%. Really terrible disease. Really terrible disease. Okay? So these are the kind of patients that you actually come in as an emergency. So trauma patients and patients who have stroke. The management of the stroke patients as well is similar to the trauma patients. Okay? They come in pre-hospital care. How fast are they getting from home to the hospital? Are they getting to a hospital that has the capacity for actually manage such critically ill patients? The guys in A&E, the doctors, nurses, healthcare providers in A&E, the accident and emergency, how have they responded to the patient? Have they jumped in, resuscitated the patient, put on your oxygen, ABCD, advanced life support protocol? Okay, have they stabilized the patient? Is the patient unconscious? Have they moved the anesthetic in? Has the patient been intubated? Is the patient stable enough? Have they gotten the diagnosis of what the issues are? Have they informed the relevant specialists, i.e. the neurosurgeon and his team? So the management is sort of similar, isn't it? It's similar where, and I will take this again, please. Pre-hospital care, resuscitation and stabilization of the patient, getting in the anesthetics if needs be, and then getting a diagnosis, and then from the diagnosis, we don't talk about definitive management of the patient. Okay, so that is the way we should do. Are we getting that across board in Nigeria? No, we are not getting it. Okay, should we be moving towards where we get it? Yes. That is why this kind of advocacy is absolutely important. Nobody, and I repeat, nobody as an individual or a group or an organization or a state or a country gets better without everyone just saying, okay, you know, by God's grace. No pressure. You understand? Everybody needs to be under pressure. The reason why the guys working very close to me say they don't like pressure because I put the whole system under pressure. And guess what? It is actually working. Yeah. It is working. Patients are getting a better deal for it. Okay? I didn't leave Nigeria and go to the UK and say, oh, do you know what? I'm 6 foot from a very fine boy. Make me a neurosurgeon. No, I went through the mill to train to become a neurosurgeon. And I hope that makes me at least average with what I do. Okay? So that's really, really important. So that's for patients, for emergency patients. And like I said, about 45-50% of the work that we do in terms of providing neurosurgical services are emergency patients. And I'll just give you an idea of what that covers. Okay. Now, the other subset I will call urgent cases. Cases that are urgent. Okay. So these will include patients who have things like brain tumors. Okay. Brain tumor, especially if it's a very large brain tumor, causing lots of pressure within the intracranial, remember cranium, intracranial, okay, yes. Causing lots of pressure. Okay, things like brain tumors, spinal cord tumors, or spine tumors that are actually causing pressure on the spinal cord or on the nerves that supply your hands and legs and stuff. Those are quite urgent. Okay, they might not be an emergency, oh, get an ambulance, but they are urgent. They are things that should be tackled as soon as possible. Okay. With respect to, I think I'd like to throw this in here. With respect to things like spinal cord injuries, okay, spinal cord injuries to the nerves, or trauma, okay, the best thing that any patient can get is that within 24 hours or top 72 hours, if there's an indication for surgery, that the patient has that. Okay, so you get a 24 hours best for at least tops 3 days. Okay, so that means that a patient maybe a patient has an accident, has a fracture to the spine and neck, or the mid back, the thorax, or the lower back, the waist region, the lower spine, and that has not affected the patient in such a way that either the patient cannot move the hands, or move the hands on the legs, or move the legs. Now, that sort of trauma, a good number of times there will be surgical intervention required. If that surgical intervention can come to the patient within 24 hours or top 72 hours, the possibility that gives you the best possibility of any recovery if recovery will happen. Okay? Femi, let's look at the realities on ground in Nigeria. Okay? First of all, looking at the provision of neurosurgical care is extremely expensive. Extremely, usually I qualify it. Extremely expensive. Look at the average Nigerian and look at the economy that we run in Nigeria. How many people do you think can actually access such a service in Nigeria? How many people do you think will have a spinal cord injury, okay, from a broken neck or a broken spine, whatever, that will come into hospital and be able to fund the care to actually get an operation within 24 hours? How many people? So it just gives you an idea of how bad the situation is, okay? And remember, let me take this as well. The appreciation of what healthcare is in Nigeria comes from the way the average Nigerian looks at the teaching hospitals. Because they are supposed to be like the top sectors, isn't it? When you go to a teaching hospital, there's no capacity, no equipment, they start on, you understand, they might have theoretical knowledge, they might have read lots of books, but in terms of application of knowledge in real time, in terms of the ability to communicate effectively, i.e. accurately, timely, and frequently, okay, there's a big struggle. One of the problems I have in Nigeria is that you have multiple big names, professor, consultant, matron, and stuff like that. But when it comes to the real deal of those names actually coming together to actually provide something for the average Nigerian patient, that the average Nigerian patient say, yes, I went into that facility and I'm very satisfied with the care that I got. Sorry, it's a major struggle, a real big struggle. But it's not all doom and gloom. There's still hope. You understand? One of our senior colleagues who also trained in the UK as well, and been back in Nigeria for maybe about 20 years or more. You understand? Was telling me one time about, oh, you know, the issues in Nigeria, we don't have a system that works and all that. Oh, you know, in UK where you come from, the system works. And I told him, I said, sir, you have been around for longer than I have, and I appreciate you have more experience on the ground in Nigeria. But I told him, I said, even with my small, teeny-weeny experience of 3.5 years or 4 years, I know clearly, Femi, clearly that even with the gaps, the inefficiencies, the poor state of our healthcare system, that we can do more than we are doing. I'm telling you the truth. And I've proven it myself. We can do better than we are doing. You understand? We are just not, as a people, rising up to the occasion. We are not rising up to the occasion. Okay? So, yeah, so urgent cases. Urgent cases, like I said, brain tumors, spinal cord tumors. And then most of the other cases will be more of elective cases. So, things like the brain tumors I talked about, most of the spinal problems, even all the other subspecialties that I talked about, a good number of those cases or those medical conditions that we look after will be elective. Elective just basically means non-urgent. You can see a patient in clinic, you can plan for operations in the future and stuff like that.
Yeah. Thank you so much. You killed quite a lot of things in that chunk of discussion and point that you put across. I want to bring it home. So maybe they're not even getting it. Let me give a typical example.
Yes.
Some people will say, oh, all this thing they're talking about, especially this is a word to our politicians, people in the position of leadership. You know, I engaged in a conversation with somebody recently, and he told me, yeah, I have beeper and I can do this, I can do that. But then I cited an example. Bring it on. We had a politician in this country, a very renowned politician. I can't mention him, who left his house. Maybe he went to another state, and then he was coming back from that state to his own hometown. This particular politician, bless his soul, he died eventually. He was on the road in a very good car, you understand? And he drove, and as he was coming, I don't know, only God knows what happened. People say that the tire bursted or something. The tire bursted, the car tumbled. Right there on the spot. Yeah. Then what you're talking about becomes a reality, because that is where the care starts, or was meant to start. This guy was, I mean, whoever, people around, they were to help. And you know the way it happens in this country. Somebody who has suffered an injury is on the floor, is supposed to be there, but people rush there and carry. If you have a cord that is unstable, a fracture that is unstable, then the dislodges. And these things happen. So a reality that we have on ground is this. Everywhere you go to, you are at risk with what Dr. Okor is saying. Now, this particular politician in those days was airlifted one way or the other, found himself, I was in England then, found himself in England. Unfortunately, he died a few days after. Suffered an injury, I think some spinal cord injury. The primary care that he needed, he couldn't get it. You understand? And this is why what you're saying, it touches my heart seriously, to be honest, because it's important for us as a nation to put up a plan where whether you are in my village or you are here in Lagos or in Abuja where you are, you should be able to get at least the primary care that you need at the time when you suffer the injury or whatever happened. Because we're all prone. I get in my car, I drive, you get in your car, you drive, we all drive. You can say a short distance, you don't know what happens. We've had situations, people just driving on the road, a car come and run into them. You're driving in your car, truck come, run into them. Things do happen in life, and it's called emergency. You have no control over it. You understand? When it happens, what can we do as a nation? And that's where that really hits me.
I think first of all, one of the things I said before was the golden hour, isn't it? That rule of the golden hour.
Yeah.
So that means whoever you are, Femi, whether you're the president, you're the Senate president, okay, whoever you are, you're the market woman, an Okada driver, a doctor, a professor, whoever you are, once that incident happens and you cannot get to a facility at least within an hour, or a pre-hospital care, you understand, is not optimal enough, or you cannot get to that hospital within an hour that has the capacity to actually manage or provide that emergency care that you need, you're gone. Where do you want to go to? How long does it take you to get to South Africa or to Egypt or to Dubai? You understand? None of these places are 2 hours, 3 hours flight. None of them. You're even talking about, there's a very senior politician, and we all know, whose son, senior politician in the country, senior person in the government, whose son had an accident. And he had his definitive treatments, his surgeries, here in Nigeria, because they couldn't edit him. Any attempt to edit him, he dies on the way. That's how important healthcare is. The 3 pillars of any developed economy are healthcare, education, and infrastructure. And you always mention healthcare first. But for a very long time, we've been playing with it. Playing with it. Even us as doctors, like ostriches, we dig our head in the sand. Not telling these politicians the truth. Not telling them, but hey, politician, you might be, and that's another major problem I have again. This thing of politicians building things up and down. And people seeing it within the private health sector as well. They all build this, or they will have equipment, or fancy equipment. If you like put all the equipment you like, build buildings, 5-star buildings and stuff like that, wasting your time. If you do not have the human beings that have the capacity, that are passionate enough, that are courageous enough, because that's what's more is lacking within our country. Courage is lacking. So everybody wants to say, oh, do you know what? Oh, the system is so bad. Let's just work. Until, and I say it time and time again, I've looked after the relatives of people who are actually very well to do in the society. And they're always like, oh, why are things so bad? I'm like, oh, really? You're asking me why things are bad? Because you understand your family member. Okay. I would have thought, Femi, that after this COVID-19 period, with the way they have really exposed the deficiencies in our business, I by now we should be stepping up and saying, hey, no, you know, this has taught us the but it still looks like more of the same, business as usual.
No, we're not the same. We're talking about people embezzling money. It's going somewhere, only God knows where it is.
So the question you ask yourself, Femi, is that when they embezzle the money and maybe they fall into this situation we talk about, they have an accident, what is the money going to do for them? If there are no facilities, no human beings, no healthcare professionals, you know, who can actually manage you and treat you, even if you want to go to abroad, they must be alive to go to abroad first. How does the money now help you?
It's terrible. So
I feel that the politicians, I think they shouldn't be greedy and selfish enough to actually build the healthcare system up in Nigeria. Just in case they have any emergency. They should, from their own selfish point, they should do it. It makes common sense, isn't it?
Yeah.
It's just terrible. So what do we do? The question was, what do we do? We keep pushing. We keep putting pressure. We keep trying to tell ourselves the truth. Tell ourselves as doctors, tell ourselves as nurses, the things we are focusing on are very primordial and not important. There's a tendency for us to focus on things that are not important in this part of the world. I see it every day. You're telling a group of people, like, hey, we need to do this. I say, oh, he doesn't like me. Who cares? Is that the priority? Why are we so emotional? Why don't we focus on the real issues that affect all of us? For example, the religion and ethnicity and stuff like that. If you're a Hausa man and you're dying and you go to the hospital, you're not caring that Igbo man, you are going to provide as long as you get the best thing. Who cares if you're Igbo or if you're Hausa or you're a Christian? These are the fundamental things we should be looking at. How do we develop a system that provides for all? The other thing in terms of capacity in the country is that when you look at, even from a business point of view, healthcare from a business point of view, I like using statistics. Do you know how many doctors we have in Nigeria? We don't have more than 40,000 doctors for 200 million people. Just about 40,000 doctors. And yet you see doctors who have finished medicals who finish house job, finish NYC, they are looking for residency sports to train, and they don't have the sports. They don't have for only 40,000 doctors. Yet UK with a population of 300,000 doctors plus, with a population of 65 million, they say, oh, we need more doctors. So that tells you that there's something fundamental wrong with us when it comes to what I call the tenets of value for human life and making value for human life a mainstream sociopolitical issue. We are nowhere near there. And so that means the pressure needs to be on. We need to keep mounting the pressure. When I talk about healthcare, Femi, I talk about healthcare from a vantage point of view of a potential patient, not a doctor. If you talk about healthcare from a doctor point of view, you will be biased. And you see, in fact, let's come back to neurosurgical services in Nigeria. Let's come back to neurosurgical services in Nigeria.
It is part of it because the neurosurgical, service is also part of this,
absolutely,
network. And obviously, now I know we've talked quite a lot about, the service that is available where you deliver and things like that. We will be rounding up anyway, but we know there are gaps which we've actually identified in terms of training, in terms of the service that is available at primary
leadership and management. Leadership, there's massive wide gap there.
That's a major one.
Massive wide gap there. In fact, that gap of leadership and management, if we feed it, more than 70% of our problems as well. That gap of management and leadership.
Yeah. Yes. So I'm involved in a particular program which I'm going to discuss with you in a bit after this program, to be honest. Whereby thinking, the way I've looked at it is, you said it. This service is very expensive. What we are getting at the point of incidence is not adequate. So what I think we need to be looking at as a nation is a situation where everybody can access this, obviously freely at the point of, of that injury or whatever happens. Somebody has a stroke. You start family. The stroke is an emergency. At that point in time is when you're now looking for money. So because it's capitalism sort of medical service that we render, it becomes so challenging to get such amount of money that people need immediately or put strain on the family. And then when we look at maybe a situation where somebody had an accident, that's an emergency. The money is not there. People don't keep money here. People get money, spend it as they get it. So it's a big issue. So there should be a way by which people get money to fund their own health system. And that's where we talk about insurance. We know that NHIS now is not really functioning. We know that a lot of effort that people are putting into one thing or the other doesn't appear to me to be working. So we need to find a way by which we need to get at least the emergency cases. We need to be able to define what that is and who can get it, so that the likes of you and other people, even in emergency institution, can actually get on doing what they're trying to do. And again, capacity building, you know.
No, that is so important. I mean, I cannot understand it because the capacity is very weak. Oh my God, very weak. Because instead of spending time and resources on these buildings that people are building everywhere, can we please spend those time and resources to build our human capacity? Oh, please, I'm begging anybody who is listening. Let's build our human capacity. I'm really worried, especially for the private players who are not doing this. They're spending more money building things up and down. Please, we need to spend a good amount of our resources and dedicate them to actually training human beings and building capacity. Please, I beg.
Yeah, so that's really, really key. And, you know, obviously we're going to round up because of the time. I wish we could just carry on. We might need to have another, maybe we have part 2 at some point. There's a lot in this discussion that is quite important. So if you have questions, I see people asking, they have some questions. You could have asked your question, but obviously because of the time, we might not be able to pick your question now. We will be answering them. I will look through those questions that you're asking, and then we will answer them. And I'll find a way of collaborating with Dr. Okor to bring him back again so that we can have, I think there's more for us to talk about this topic.
Femi, you can just call me Douglas. Which one is the problem?
Okay. All right. So we will have to have a part 2 of this definitely, because there's no how we can, I realize we can't handle this within the time we have. So I really want to appreciate you and thank you for, you know, the time and always, you know, doing all these fantastic things. And I agree with you that, you know, Nigerian patients is worth it.
Nigerian patients are worth it, bro. They are worth it.
Yeah. So we are in it together. I hope our colleagues can key into this, and then we see how we can work together collaboratively, a you know, disciplinary approach to care, whereby we can deliver quality for people, and then increase capacity and build on what we have now, so that
and actually get to a point where we actually reverse medical tourism from other West African countries into Nigeria. We can do it.
Yes, I agree absolutely with you. Yeah. You know, I totally agree, and it's all about collaboration. It's all about you know, engaging the right piece. Just like you've been doing, you've created a big track. I keep watching your, you know, all those things that you do and you post on LinkedIn and.
God be the glory.
Yeah, well done so much. So, to the audience, thank you so much for joining us today. We're going to the end of this. We will be bringing Douglas back to come and tell us more, because I don't think we have actually finished what we need, what we've started. So, and then we'll communicate this across to you. So thank you so much for joining us today. And then look forward to seeing you again in maybe next week or in between during the week if we have anything coming up. Thank you and have a nice weekend. Bye-bye.
Cheers.